I am Dr. Iqbal from Forensic Medicines. Now the topic is intracranial hematoma or intracranial hemorrhages. Intracranial hematoma or hemorrhages is classified into are classified by anatomical locations: extradural, subarachnoid, subdural, and intracerebral. Intracranial hemorrhages is a common complication of head injury, and it is the most common cause of the death in patients who experience a lucid interval. Lucid interval, that is, patient is recover between two unconscious periods, that is, it's talk and die, or talk and deteriorate after injury. Clinical complications associated with a hematoma are related to the size, volume of the lesions, the anatomical location, and the rapidity with which it develops. Hypovolemic shock cannot be happen from the intracranial bleeding. There is not enough space inside the head for the amount of blood loss needed to produce shock. A spending hematoma should be distinguished from the delay hematoma, which are the lesions that occur 24 to 48 hours after the time of injury and are not evident on the initial imaging studies. It reflects increased blood flow or pressure through a vascular capillary network that are focally damaged, compounded by post-traumatic coagulopathies. In several cases of death due to blunt force head trauma, the only intracranial injury that are evident at autopsy include subdural and subarachnoid hemorrhages. As you know, hemorrhage it's a copious discharge of the blood from the blood vessel, whereas the hematoma, it is a localized collection of blood in the tissue, usually clotted or partially clotted. Apoplexy is a sudden, large effusion of the blood in an organ or tissue. The term is synonym for cerebral. So, first we have talk about the extradural or the epidural hematoma. As it is definition, it is a bleeding occurring between the inner table of the skull and the meninges, that is the dura. Causes mostly traumatic in origin and unilateral. It is seen in the fall and road traffic accident, up to 10% of severe head injury cases. The silent feature of this extradural hemorrhages, it is occur usually on the side of the impact and common in adults between 20 to 40 years, as the dura is able to strip more rapidly of the underlying bone. It is infrequent in the elderly and the young, less than 2 years, due to greater adherence of the dura to the skull in both these age group and absence of bony canal for the artery in the young. It shows typical limitation due to the dura attachment at the suture lines. Fractures like the fissure type is present in most of the cases, 90 to 95%. In children, extradural hemorrhages may be seen even without skull fractures. It forms a circumscribed ovoid or disc-shaped blood clot that progressively indent and flatten the adjacent brain. Size and extent of extradural hemorrhage is determined by the source of bleeding, either the venous or the arterial, and it is the strength of attachment between the outer layer of the dura and the cranium. Artificial epidural hematoma can occur in the fire victims related to heat-induced postmortem skull fractures. Side and the vessel involved due to impact of the lateral convexity of the head, resulting in the fissure, fracture of the squamous temporal bone with rupture of the underlying middle meningeal artery, which is direct branch of the internal axillary artery, the commonest cause. Forehead that may tear the interior ethmoidal artery. Occiput that may tear the transverse segment sinus. Vertex that may cause the hemorrhage from the sagittal sinus. fracture of the skull with tear of the diaphragmatic vein and the middle meningeal vein. Here is the pictures which show the epidural hemorrhages, subarachnoid hemorrhages, subdural hemorrhages and the intracerebral hemorrhages. You can see the epidural hemorrhages. The fractures on the skull lead to the bleeding between the skull and the dura mater, and the middle meningeal artery which is affected. In case of subarachnoid hemorrhages, the bleeding is the subarachnoid space, where you can see the subdural hemorrhages. There is bleeding between the arachnoid and the dura mater. In case of intracerebral hemorrhages, the bleeding inside the brain. The types: acute onset is within few minutes to few hours or even a day. It is the arterial bleeding. In case of chronic, symptoms are slower in the onset, 48 to 72 hours after trauma. It is rare and commonly associated with the tear of the venous. Clinical features: there is loss of consciousness due to concussion, dilation of the pupil on the side of hemorrhage which conjugate deviation of the eye to the opposite side. There is bilateral fixation of pupil, and the important one is the lucid or the latent interval. It is the state of consciousness between the two episodes of unconsciousness. The mechanism of lucid interval is, since the initial brain injury is only a concussion, subsequent middle meningeal bleed cause the ensuing decompensation for the expanding blood collections, causing increased intracranial pressure and a reduction in the cerebral perfusion. Feature of the cerebral compression supervene and may lead to coma. Another is the decerebrate rigidity and death due to the respiratory failure. Frequently, patients present in a coma and require an urgent craniotomy. It is a surgical emergency, and it is early diagnosed, and intervention usually saves the patient. The brain itself is not significantly injured, and the bleeding originates from the outside the brain parenchyma. Diagnostic tool is the CT scan. It produces a biconvex lenticular shape hemorrhages due to adherence of the dura to the inside of the cranium. Isolated EDH of less than 2 cm, about 30 ml in the volume, may cause an alteration in the level of consciousness or a focal neurological deficit. Autopsy finding is the temporal scalp contusions on the side of hematoma. Hematoma in the epidural space, on removal of the skull cap along with the fissure fractures of a temporal and a small thrombus on the surface of the middle meningeal artery there may be seen. Diffuse brain swelling and cerebral contusion may be seen. Subfalcine herniation extending from the side of the hematoma to the opposite side, and the transtentorial herniation which is usually more marked on the side of hematoma. Soiling of the cerebral hemisphere under the hematoma cause the effacement of a sulci and flatness of the crest and the gyri, which give a smooth appearance. The medico-legal aspect: prognosis is good with proper treatment. Hematoma on the contralateral side should be carefully excluded. Patient may be discharged from the hospital during lucid interval and die at home. Doctor may be charged with negligence. Most complications occur within the first 24 hours following the injury. Patient attendant should be instructed on what sign to look for and when to return for further care. The condition may resemble drunkenness, and the patient may die in the police custody. Presence of extradural hemorrhage may or may not cause death. The possibility increasing with the increased volume, blood, duration of injury and the presence of herniation from subdural hematoma. It is a collection of blood in the subdural space, that is between the dura and the arachnoid membrane. Side as mentioned below, the most common side is the lateral aspect of the cerebral hemisphere. The least common side is the posterior cranial fossa around the brain stem and the cerebellum. Mechanism in traumatic lesion, there is a gliding type movements between the dura and the skull cause one or several bridging vein causing subdural hemorrhages. Thus, in majority, subdural hemorrhage is venous bleeding and bridging vein are the major sources. Sometimes subdural hemorrhages is arterial in origin and it is caused by a small rents in the arachnoid and the adjacent cerebral arteries. Okay, here is the normal anatomy and the various intracranial hemorrhages. A show the normal anatomy and the B you see the brain substance having the hemorrhages, and it is the subarachnoid hemorrhages. Where the C, picture C, you can see the extradural space, there is a collection of blood and it is the subdural hematoma. Another picture, which one, D, you see the subdural space, there is a collection and it is the subdural hematoma. In this picture, the mechanism of formation of subdural hemorrhages is exposed. There is the gliding movement between the dura and the skull which lead to the rupture of the bridging vein, and this cause the subdural hematoma. Here is another scanning, a CT scanning, which show the red arrow with the subdural hematoma. Another picture will show the subdural hematoma. The classification of the subdural hematoma into three types. Acute is the patient present with the 48 to 72 hours of injury. The subacute type is the patient represent 3 to 20 days, whereas in chronic, patients present from 3 weeks to 7. Acute subdural hematoma, here is the trauma is a common cause and may be associated with the closed or open head injury. Mechanism involved in causing the acute subdural hematoma is change in the velocity of the head, either acceleration or the deceleration with the rotation component. Mostly in case of vehicle accidents, front seat drivers. Subdural hemorrhage is quite mobile and may graduate to lower side, thus do not depend on the side of application of force. It is a common lesion that extradural hematoma and 35 to 100 ml is required to cause. The clinical feature of the acute subdural hematoma are the onset of the symptom are delayed as the bleeding is of venous origin and take longer time to accumulate. Here is also the lucid interval is present. There is a gradual decline in consciousness and may have speech defect. Ipsilateral papillary disturbance, hemianopia and the contralateral hemiparesis. The chronic subdural hematoma, the lesion is found commonly in the older pupils or chronic alcoholic. In these people, there is a usually atrophy of the brain, and due to which there is an increase in subdural space. This increase in the space permits more free movements of the brain within the skull. Thus, there is a higher risk of rupturing bridging vein. In this table, The causes of subdural hematoma, they are mainly the trauma and the pathological. In case of trauma, due to the rupture of the bridging vein, duravenous sinuses, laceration or contusion of the brain and the dura. In case of pathological, there is a rupture of aneurysm, malformed blood vessels, hypertensive bleed within superficial part of the brain that rupture in the subdural. Subdural hematoma from the natural causes is often bilateral, while the traumatic variety, it is usually unilateral. When passage of the time, subdural hematoma become organized and encapsulated. The gross appearance of subdural hematoma varies with the age. In case of recent lesions, which is up to week, are red-brown with a gelatinous membranes covering the surface. The content are thick with central part remaining fluid. In case of the older hematoma, up to the month, it is firm with tough membrane on both sides, both surfaces. The content may be liquid or firmness and variegated. Location is common with depressed underlying brain. Repeated trauma may cause repeated hemorrhages. Successive hemorrhages increase the volume of subdural hemorrhages and which cause the neurological symptoms. This type of hemorrhages is known as pachymeningitis hemorrhagica. The medico-legal importance, clinically symptoms may be mistaken for schizophrenia, senile or the senile dementia. Lucid interval is present in subarachnoid hemorrhages. It is the hemorrhage in the subarachnoid space between the arachnoid and the piameters mixed with CSR. The subarachnoid hemorrhages occur in the subarachnoid space that is between the arachnoid and the piameters. Here is the CT scan showing the subarachnoid hemorrhages on the left side of the temporal region. The subarachnoid hemorrhages due to the rupture of the aneurysm. Picture show in the subarachnoid space. The cause is mostly the venous in origin, non-traumatic on the natural causes. It is due to the rupture of the developmental aneurysm of the vessel in the circle of veins. Excluding head trauma, it is the most common cause. 70% of cases of subarachnoid hemorrhages, especially in the young adults. Atherosclerosis. Atherosclerosis changes in the blood vessels associated with hypertension in the elderly subject. Arteriovenous malformations in 10% cases. Leaking intracerebral hemorrhages. Disease conditions like purpuric state and leukemia. The traumatic causes are cerebral contusions or laceration, explosive blasts, asphyxia by strangulations, traumatic asphyxia, blow to the neck, accidents, fall and cervical manipulations cause damage to the cerebral or the basilar arteries. Rupture of the traumatic intracerebral hematoma into the subarachnoid space or into the cerebral ventricles. Prolonged hyperextension of the head during bronchoscopy. Bleeding originates from the veins in basilar or the vertebral arteries. It is lead to be a charge of negligence. The silent features. Subarachnoid hemorrhage is common in the traumatic brain injuries. Even in the minor head trauma, a small amount of localized subarachnoid hemorrhages over the cerebral convexity is almost variably seen. Like subdural hematoma, the location does not correlate with the site of the impact in the blunt force trauma, but usually subarachnoid hemorrhage is most prominent close to its sources. Subarachnoid hematoma is extensive because CSF and unclotted subarachnoid blood flow freely in the subarachnoid space. The types, immediate or the delayed the reactionary hemorrhages until the initial contraction and the retraction of the vessel has submitted. The clinical features. There is a sudden onset of severe unusual headache known as a thunderclap headache. There is nausea and vomiting. There is neck stiffness, photophobia, drowsiness or agitation. Depressed consciousness. The physical finding in case of subarachnoid hemorrhage is the meningism and the positive connect sign. Diagnosed by the non-contrast CT scan, it shows hyperdense blood collections along the flanks and it is in basilar strand. Lumbar punctures should be performed. CT scan is not yielding sufficient information. LP will reveal the CSF intimately mixed with blood coming under the increased pressure. Differential diagnosis is bacterial meningitis. The medical legal aspect, atherosclerotic vessels in older person with high blood pressure ruptures more easily than normal ones. It is possible to testify that trauma has caused or predicted the rupture of the developmental barrier aneurysm. Subarachnoid hematoma can be produced post-mortem secondary to decomposition in the cases of lysis of RBCs. Intracerebral hemorrhages. Here the hemorrhages occur in the cerebral tissue. It is also called the parenchymatous hemorrhages. The causes may be traumatic or non-traumatic. Trauma, in case of trauma, laceration of brain, blunt trauma with or without fractures. In non-traumatic cases, they are the pathological causes, the hypertension, arteriovenous malformation, spontaneous hemorrhages, and bleeding into the plasma. The features are the traumatic intracerebral hemorrhages, measure from 2 to 5 cm in diameter and are demarcated. These hemorrhages result from the shearing forces that tear blood vessels in the parenchyma. If persists, the hematoma gets organized with encapsulation. Multiple punctate hemorrhages may be seen in the bleeding diathesis, septicemia, and the fatum. Intraventricular hemorrhages. Here the hemorrhages occur in the ventricular system of the brain. The causes is due to the trauma or due to the pathological causes. In case of trauma and second is the non-traumatic causes, that is the pathological causes. In the pathological causes, the retrograde flow of the subarachnoid hemorrhages into the ventricle, rupture of the arteriovenous malformation in the wall of ventricles, rupture of barrier aneurysm of posterior communicating arteries, and bleeding into the anterior portion of the horn of the lateral ventricles, rupture of the barrier aneurysm of basilar artery through the floor of the third ventricle. The feature in this case, the ventricular hemorrhages is usually arterial in origin. If intraventricular hemorrhages is sole finding, it is result of head striking a firm object as in a fall or fall-like injury. Brown or yellow discoloration of the ependyma, choroid plexus, and the leptomeninges are due to the deposition of hemistrine and the Claudine and suggests the presence of old. Okay, it's all. Thank you.